The next speaker is Cyril Sarek, speaker on intraoperative support for lung transplantation.
Thank you. I have nothing to disclose. Dr. Kajavsky gave a good overview of why we use ECMO now as our preferred choice. I mean, we started in 2012, and then approximately 35 to 40% of our patients now require intraoperative ECMO support. And basically, we do see less intraoperative requirements for blood products, as Dr. Kajavsky said, better early outcomes, but there still is a role for cardiopulmonary bypass, but usually in emergency situations and concomitant cardiac surgery. So intraoperative ECMO versus cardiopulmonary bypass. So exactly what is it? The big difference is ECMO is basically we can just use it for partial circulatory support during the transplant procedures. It can be central peripheral cannulation. There's no cardiotomy reservoir, no cardiotomy suction. ACTs are between 160 and 220. We have a very small surface area compared to conventional cardiopulmonary bypass. Prime volume is about 400 mils, and we have a closed circuit with a kinetic pump assist. Cardioplegia in our configuration is not an option. And as I said, we do have conventional cardiopulmonary bypass ready in our room just in case we do require it, but usually it's draped up in the corner and on the opposite side of the room. So if you look at our circuit, we take the philosophy, keep it simple, safe, and effective. So components, basically we have an affinity pump, quadrox oxygenator, heparin-coated circuit. These are devices that are approved for cardiopulmonary bypass, not necessarily long-term support or long-term ECMO support. So we keep it simple, no bridges, no pressure monitors, we don't use saturation or sample ports, and no fluid ports as well. So the big advantages we feel is increased safety, less turbulent blood flow and cellular activation, and less area for stagnation and clot formation. And this is just to show you basically the hemodynamic stability that we can achieve on ECMO. We have 5 liters a minute, and you can see that the patient's hemodynamics is very good, and you still get some cardiac output, and so we're not achieving 100% of support. So our coagulation protocol, basically we just give 60 units per kilogram of heparin for a target ACT of 220 or greater for cannulation. And then we let the ACT go down to 180, and we'll start a heparin infusion at 500 units per hour. If the ACT goes less than 1 or down to about 160 during the case, then we'll just bolus with about 1,000 units of heparin at a time, targeting the ACT during the case from 160 to 180. We do use low-range ACTs, and I think this is very device-specific. So we use the Hemocron Elite. So we use the low-range ACTs for these cases, as we find the high-range ACTs do not give very accurate results for the ACT level that we're looking for, and we'll run ACTs every 30 minutes. Cannulation, as Dr. Kajavsky has mentioned, normally most people use a 32 French single-stage venous cannula. We Others prefer a 3240 dual-stage cannula and a 20 French Medtronic EOPA straight arterial cannula. Peripheral cannulation is rare. We still prefer VA ECMO, and this is just a diagram of basically two ECMO circuits simultaneously. So we have the VV ECMO, long-term ECMO going here, which, as we said, we just lower the flows down to about 1 liter a minute while the surgery is done, and we use our central ECMO where we actually VA ECMO, our central VA ECMO, where we actually support the patient. A few tips and pointers that we've learned along the way. We're not really trying to achieve a cardiac index of 2.4 like you would cardiopulmonary bypass. An index of 2, 1.8 is fine to support these patients as long as they're hemodynamically supported. Everything is okay, so don't get too caught up in trying to achieve that full flow. Low flow scenarios, positioning is a big one. Usually, if you don't get, if the cannulation is not good at the beginning, you will get low flow, so just check and reposition that cannula. Otherwise, if the cannula position is good, then you have a volume status to deal with, and we get anesthesia to give volume replacement. Usually you will see a decreased flow when they're doing the LA anastomosis. So again, don't worry about it. Just decrease the RPMs to the maximum flow that you can get. And when you're perfusing that first lung, when you're doing a double lung transplantation, you just want to lower the flow as they reperfuse the lung, and you want to maintain that low flow as a protective strategy for the lung, and make sure that you get some ejection out of the PA, and that flow is that first lung is actually actively being perfused now. Small amounts of venous air, we're not too worried about it compared to conventional cardiopulmonary bypass. Basically, the procedure is the same. You get venous air, you decrease your flow. With conventional bypass, you'll just walk the air out of the venous line. With the intraoperative ECMO, we will purge it through our oxygenator. Obviously, you have to fix the problem and then recommence circulation. And the video is just showing you the oxygenator actually taking care of the air. Massive air, unfortunately, is not as easily handled with ECMO. Conventional bypass is definitely easier. But if you can't get rid of the massive air, then we would just clamp out, try to reprime, or you could switch the circuit to another ECMO circuit, or switch to conventional cardiopulmonary bypass. We have talked about using some venous air removal devices. Medtronic has what they call a VARD, which is basically has an ultrasound sensor which detects air, and as it sees air, this is basically hooked up to an outside vacuum source. So when it sees air, the vacuum just basically takes the air right out of the venous line. The unfortunate thing is you are increasing your surface area, you're increasing your prime, and because of this, you may need to potentially increase your ACTs. So we haven't been too keen to adapt to this technology. And to be quite honest with you, we can't say we don't see venous air, but it is rare. As I alluded to earlier, you can use any oxygenator that's basically approved for circulatory support for cardiopulmonary bypass, and we've used the Medtronic Affinity, we've used the Fusion as well, but our go-to oxygenator is the Quadrux. If you look at plasma exchange, we've another therapy that we help out with for support for our lung transplant patients. We all know that patients who are sensitized to HLA antigens have worse outcomes after transplant. So we've designed, the lung transplant program has designed a protocol to manage these sensitized patients. And basically, we just use plasmapheresis intraoperatively and run a 4-day course postoperatively with IVIG and ATG supplements. If you take a patient, we'll do a virtual cross-match. Obviously, if the virtual cross-match is negative, we proceed with the lung transplant. If it's positive, then there's a number of scenarios. Obviously, if it's positive and the actual cross-match is negative, then we would proceed with the lung transplant. But if the actual cross-match is positive, or if it's not available at the time, then we will go to do plasmapheresis. And our approach certainly seems to work, and it looks like, as we've published our results in 2015, that we've really removed this postoperative risk of positive cross-match patients using plasmapheresis. So one thing we used to do when we were on conventional bypass and plasmapheresis, we used to withdraw, hook up the plasmapheresis line, so we withdraw from the cardiopulmonary bypass circuit. So we withdraw from the recirc line and return to our reservoir. This ran us into a lot of problems. So high pressure alarms on the plasmapheresis device for one, but the biggest one was basically the difficulty to maintain our ACTs. And we would see this especially when giving FFP at the end of the exchange. And we would see dramatic drops in our ACTs leading to subtherapeutic levels, ACT levels. So this often resulted in clotted reservoirs during cardiopulmonary bypass. So this is not very good for perfusion staff retention. So we've decided to do something a little bit different. So now we use a angiocath, which is basically a 12 French dual lumen catheter, which the surgeon will basically place prior to surgery. And our return line from the apheresis device will be connected to this, and we will not connect directly to our ECMO circuit or to cardiopulmonary bypass circuit. And again, this has the advantage as it can be used postoperatively in the ICU, because as you remember, we do have to do plasmapheresis every day for 4 days post-transplant as well. Anticoagulation protocol for this is basically patients are anticoagulate the same as per our usual protocol. Citrate is used for the apheresis unit, 8:1. We do use our return heparin infusion in the return line of the plasmapheresis. This ensures the infusion is, we set it at the beginning at 2,000 units per hour, which could be a little bit high considering normally we run at 500 units, but this certainly ensures that we're returning heparinized blood back to the patient, and we'll decrease this infusion as necessary. And again, we'll monitor our ACT every 30 minutes. So it takes approximately about 3 hours. It flows of 120 mils per minute to complete the apheresis. The volume of fluid replaced is based on the patient's height, weight, and hematocrit. We use a hematocrit of 24 on cardiopulmonary bypass. Obviously, due to hemodilution, this is just a number that we use. It doesn't necessarily mean that that's what the patient's hematocrit is on cardiopulmonary bypass, or ECMO, I should say. We don't use the patient's preoperative hematocrit to do this fluid replacement calculation. So there's 3 plasma volume exchanges. The first 2, which is about 2.5 liters each, replaced with 5% albumin. The third plasma volume is replaced with FFP. And what you actually, the thing is, again, at the end, when you're giving FFP, just make sure that you watch the results and watch your ACT, because we do expect the ACT to fall. So we just notify the perfusionists and make sure they know when the FFP is coming in and that they actually prepare for that. And that just makes it easier to retain and recruit perfusionists. And this is my team. Thank you very much.